now, from after anatomy and these things, physiological stuff, the main diseases that we see in the urethra are either urethritis, the infection of the urethra, urethral strictures, the most commonest disease which comes in the field of or department of the urology. And other than that, urethral meatal stenosis is one of the other diseases. Urethral trauma, urethral cancers, polyps, or the very rare diseases, cancers and polyps. It's very rarely seen in all of my 10 years or 12 years experience. I've only seen one patient of urethral cancer. And anyway, the urethral congenital diseases comprise of hypospadias and the epispadias, which is covered in pediatric surgery. So we will not be discussing here. Coming to the basic disease, which is very commonest disease and seen in most of the female patients and male patients, it's urethral stenosis. When in the males, you can see the normal slit of the urethra is seen over here, but there is a very narrowing of the urethra here. So a patient comes with the difficulty passing urine, and along with that, the stenosis leads to the thin stream of the urethra as well. Same over here in females. Either it happens in congenital diseases with the kids, or sometime with the postmenopausal age of the females. There is vaginal atrophy, which leads to the urethral stenosis here. And the treatment for both is very simple. It's just a urethral dilatation, which is the overall management for urethral stenosis, mainly the meatal stenosis. Sometime in males, when there is some congenital anomalies along with urethral stenosis, we may need meatoplasty, reconstruction of the meatus. So in some cases, usually it's just a urethral stenosis, which is treated with the urethral dilatation. Okay, the other thing is urethritis. It is actually associated with sexually transmitted infections, and the most common organisms which causes STI is chlamydial infections, or it is Neisseria gonorrhea. Urethritis can be because of other infections like with the E. coli or other organisms other than STIs, but that's very rare to cause urethritis. So how do you investigate? There's pus coming out from the urethra. So you need a urethral smear from the urethra to diagnose the urethral infection. And the other tests that we go for in urethritis are gram-stain culture is from the urethral cell, the same thing. But other one is nucleic acid amplification test, enzyme immunoassay, or serum rapid plasma regain. So these are done for the other diseases related with STIs, not actually for the bacterial infections. So the urethritis empirically is treated with two kinds of antibiotics according to type of infection. That's fluoroquinolones are given for gonorrhea, and azithromycin is given for chlamydia. The choice of drug is fluoroquinolones because it has a very good penetration in the urogenital system, especially in the prostate tissue. And how long you are going to give the antibiotic? It's around 6 weeks. If it is a major urethritis and persistent pussy discharge, you might need to go for 6 weeks, and then you repeat the culture to reconfirm if the disease has been recovered, or it's still pus coming out from that. So if it is not treated by the time, then it can even lead to the urethral abscess or abscess formation. And after that, you can't treat the abscess with the medications only, because it can lead to antibioma. So what you need is you have to drain the pus. And draining is either percutaneous drainage with the needle passing, ultrasound guided, or you can go for incision and drainage of the pus area. If you have good access from outside, it's better to go for incision drainage. But if there's small abscess or collection, then you can go for percutaneous drainage as well. So the main topic, the main thing is urethral stricture, which is associated with urethra. It's a narrowing of the urethra at any part. At any part of the urethra, if there is narrowing the urethra, it can lead to the obstruction and decreased flow of the urine, and very difficult in passing urine. So it can be a small one or it can be a very long stricture as well. So defining the urethra is divided into 5 parts as we discussed: anterior and posterior urethra. The anterior urethra comprises of navicular fossa, penile urethra, and then this is a pulbar urethra. This is this all is anterior urethra, and the posterior urethra is membranous urethra and the prostatic urethra. Okay, so the stricture is usually, we say stricture disease when it is in the anterior urethra, not in the posterior urethra, because if it is in the posterior urethra, we call it as prostatic injury or urethral fracture, urethral injuries, rather than saying or there's invasion in the membranous urethra, but rather we do not call it as stricture. The stricture is really from the anterior urethra. Causes unknown, 41%. It's idiopathic. You never know the cause. There's no history of trauma, no infections, nothing at all, but still have a stricture. Sometimes you don't need to treat stricture. We'll discuss that later. The other reason is trauma, the commonest one, and the catheterization, trauma by the catheter, instrumentation done in the urethra, the radiotherapy given, radiotherapy management given for oncological radiotherapy actually, given for any pelvic diseases, the TURP done, or there's infection of the urethra with gonorrhea, like we said about urethritis, can lead to the urethral strictures if they are not treated by time. So what's a pathology? There's a noxious stimulus because of the bacteria, the chemicals present there, which leads to denuded epithelium, and there's really metaplasia over there. Fissure development is seen in the epithelium. Once there's fissure development, the extraversion of the urine into the into the corpus spongiosum, which leads to the fibrosis of corpus spongiosum. Then there is very hard strictures, but the very simple strictures are just related with the epithelium. Here you can see this is epithelial stricture, one valve and the bilateral bivalve urethral stricture, and you can see there's a very thin narrowing, but this is very soft stricture because this is just comprises the epithelium. But if there is extravasation, which leads to the fibrosis in the spongiofibrosis, in the corpus spongiosus muscle, which leads to the spongiofibrosis. And once there's the fibrosis, it can lead to the very hard strictures, which usually need to be removed completely. And if there is fistula in the stricture, and then it can lead to the urethrocutaneous fistula as well in very long term. So usually, what is the presentation of the patient? How does they present? They usually present with a poor stream and incomplete bladder emptying, hesitancy, and dribbling of the urine. Patient may present with the recurrent urinary tract infections, acute urinary retention, complete obstruction of the urine. If there is complete obstruction of the urethra, complete narrowing, then it can lead to the acute urinary retention. Hematuria is one of the commonest problem with the strictures. Usually there is terminal hematuria in the stricture diseases, but sometimes there is initial hematuria as well, but there is no mixed hematuria in the patient with urethral diseases. So with investigations, what is our aim is? Our aim is to find out the location and the length of the urethral stricture. So there are two studies, two investigations which are very commonly done and which are very must to be done. There's one is flow studies, the uroflowmetry to check the flow of the patient, and the other one is radiology. With radiology, we need to go for uretherogram. See, radiological investigation, we need a uretherogram. This is a must test to confirm the urethral stricture length and its depth. And the other one is flexible endoscopy can be done, which can tell you that the urethral stricture, but it will not give you the complete length of the urethral stricture. Uroflowmetry is the commonest test that we advise. Here you can see a patient who's peeing in the jar, and you can see the flow of the urine. It increases, it goes up to the peak, and then just comes down. It all depends on the urethra. The lumen, as it expands or dilates, the urine flow increases, and when it squeezes, the flow comes back. But when there is stricture, with stricture, as you can see, as we saw the pictures, the urethra cannot expand further. It remains collapsed at that part. So the flow cannot go up. So in that scenario, the flow remains straight line. With a straight line, the lumen cannot expand or cannot dilate further, so it extended or dilated that much, and then the flow is equal, same flow for the whole of the urine. Same, this is a patient picture, uroflowmetry. Here you can see also this is a straight line of the urethra, of the flow of the urine. So here we can diagnose with that, and the other one is cystoscopy or urethrotomy. You can see here this is a dilated urethra where there is no narrowing, but here you can see the whole urethra is compromised with the stricture, and which leads to the very small narrow opening in the urethra. So these are stages. In stage 1, this is a very simple urethral stricture which actually does not cause much symptoms. But stage 2, when there is a good narrowing, but lumen is very visible and a broad lumen, so still there are symptoms. There are symptoms, but yet you do not see there's no complete obstruction. But here you can see hardly the lumen is visible with this stricture, and over here in stage 4 there is no lumen. That means complete obstruction of the urethra is done, and because of that, a patient will be presenting to you with complete retention of the urine. The patient cannot pee. So the final investigations, uretherogram. This is a must investigation should be done. This is a normal uretherogram, normal urethra, exposed bulbar urethra, and the prostatic urethra. But here you can see there's a trauma and there's extravasation of the dye coming out of the urethra. Over here you can see this is a bulbar urethral stricture, very narrowing here. So that's why the dye is passing up, but with a very narrow part over here. And over here you can see there's a long stricture. This whole part is comprised of stricture, but there's some places there's dilatation, some places there is narrowing, and here you can see there's a complete narrowing over here. Same, this is a micturating uretherogram when the patient is asked to pee. When he's peeing, you can see there is narrowing in the urethra. This is the bulbo-penile urethral part. So treatment, in the absence of complications, treatment is for symptoms. And if the symptoms are not particularly troublesome, treatment is unnecessary. As I told you, with the stricture, which is completely open, grade 1, where the patient does not have any symptoms, you can leave it. You don't need to treat every stricture. But with the grade 2 or above, you need to treat those patients. Okay. What are the treatments? Simple one is the dilatation, and which is for the epithelial structures. But if there's a spongiofibrosis, you cannot go for dilatation. And actually, the dilatation is nowadays not recommended since the optical urethrotomy is present. In optical urethrotomy, you need a stricture of no longer than 2 centimeters, and you should know where to cut. It's always at the 12 o'clock where we cut the urethral stricture. And there's a reepithelialization afterwards, and once the reepithelialization is there, before the contracture or the stricture contracts, so then there will be no problem. But if it contracts early and there's no reepithelialization, there are chances of restricturing. So that's why we keep the catheter inside for 3 days at least, so it should not contract back. Here you can see the pictures of optical internal urethrotomy. This is a stricture where he's cutting down with the old knife, 1 and 2. Now here, the stricture is cut. So you can see this is a broad opening now, which was very narrow initially. Complications can be urine extravasation, pain, urinary tract infections, or sometimes erectile dysfunctions, but this is very rare with the optical urethrotomy. Again, the picture of the urethral stricture. Over here. So in case of recurrence, if there is recurrence in the urethral stricture, then you can go for repeat urethrotomy. You can treat the stricture again with the urethrotomy, but you might need a laser type of management in that. And you can go for open surgery. So this is the definitive management, the open ear surgery or urethroplasty. A laser management of once you have done the uretherotomy with a cold knife, you can go for laser one, and the commonest laser are used are carbon dioxide and or the Holmium laser. With the laser, as you can see here, the narrow part is wide open. With the laser management, it vaporizes the whole tissue from the stricture tissue from that area. The stents are done in those patients only where a patient definitive surgery cannot be done for the time being. So patient has gone recently through any of the cardiac surgery and he cannot go for the urethral surgeries at that moment. You can actually take time and ask take the time and go for this temporary procedure till he is completely recovered from other diseases, that he can go for the definitive management. The uroloom is kind of the tubes which are placed. Okay. Well, repeat uretherotomy is done one time after once it has been failed, but not the other time. Here we discussed before about the parts of the urethra. So we need to go for urethroplasty, and it will be in the bulbar urethra, penile urethra, or posterior urethral reconstruction may be needed. Okay, there's the main surgery that we do with the urethroplasty is anastomotic urethroplasty. How do you do that? You remove the stricture part of the urethra, and then you completely remove it, especially the upper and lower part of the urethra, and re-anastomose both of the parts. It's called as anastomotic urethroplasty. It is done for those strictures which are less than 2 centimeters, and the outcome is around 90 to 95% in those patients. Complications are ejaculatory dysfunction in 20% of patients. Poor glands erection is seen in 11% of the patients. Augmented anastomosis is done also, in which you take a graft and place the graft here, because you have very narrow part and you have long stricture. You cannot completely remove and re-anastomose both of these, because with the long stricture you don't have space. So you need what you do, you open a part of it and place this graft and re-stricture above that. So you have a broad part of the urethra availability. So with the graft, there's 2 procedures in Imbibition in which is for 48 hours, where the graft takes nutrition from the host bed, and Inosculation when the graft is taking his supply with the circulation. The circulation has been developed along with that graft. You will discuss these grafts in the plastic surgery. So graft example where you can take graft from is either from skin, buccal mucosa, bladder mucosa, or rectal mucosa. Buccal mucosa grafts are usually taken for the urethral strictures because these are easy to harvest, easy to handle, and they are thick, easily they take a chip easily, and they are waterproof, and they have very good responses. The buccal, this is one of the picture where we take the buccal mucosal graft. Okay, there are flaps also mostly the flaps are taken from the penile or superficial skins, but there are other places where you can take the flaps as well. So here, one of the examples that I have put here to make a good understanding of it. Here you can see this is a superficial skin. Here the graft is taken from the superficial skin and this is diverted and placed over the urethra over here, and then it is closed. So in this way, you can take a graft and place over that part of the urethral stricture. Here you can see this is a long stricture, along with long strictures. You cannot go for anastomotic urethroplasty. You always need a graft. So with the graft, you always go for, you sometimes need 2-stage surgeries, or you can even go for 1-stage surgery. There are always rooms for you, spaces for you to decide what you want to go for. Okay, the last thing is, which is not very common, again, urethral cancers is very rarely seen in adults, and usually it is associated with the STI, sexually transmitted infections, in which there's herpes papillomavirus, which is common sexually transmitted infection called virus, and this can lead to the urethral tumors. 80% of them are squamous cell tumors, and 15% of them are transition cell tumors. They do not appear if there is no STI or there is no urethritis or any other diseases prior to them. This is extremely rare to have a urethral tumors or cancers. Here you can see a female patient. There is a meatal tumor. Just beside the meatus, there is a tumor development. From inside endoscopic pictures, you can see this is a tumor arising from the urethra. Over here, you can also see there's a tumors arising from the urethral wall. So tumors are actually treated by two ways. Either there's a very small tumor, you need a laser treatment. With the laser, you can just vaporize the whole of the tumor part if it is not penetrating and if it is only present in the epithelium. But if it is deep inside, you need to remove a urethra. You might need to go for penectomy, or you might need